In real life?
Okay, I think in the res commitment to time and everybody's time, we're going to open this forum today as people are joining. My name is Victoria Stephen. Thank you all for joining us today. I'm the interim executive director for the IHI. This is a really important topic today, and so we really appreciate everybody's attendance and your participation because this really is going to be a interactive forum. We need your input, we need your knowledge, your insights, your awareness as we look at the challenges with rural health in the Inland Empire and also across the state. And as we look at the federal rural transformation funding that's going to be coming through RFPs sometime in the next, we believe, month or two. And so this is the opening dialogue, at least through the IHI, of having an opportunity to really talk about what we're seeing and what we're needing and how we can maximize the use of this transformation funding as we develop appropriate collective and collaborative and what I call complementary RFPs so that all of the funding comes into the IE and is used effectively and efficiently. So again, thank you everybody for joining us. We're going to start with two presentations, and then we're going to put you out of work in breakout sessions. So our first presenter is Annie Adriasian from 211. Annie's a data analyst and correlates all the data for 211 across the two counties. And so she's going to be sharing what 211 has seen in rural mental health in 2025 in the way of the calls they've received and the topics they've requested. And then Annie's going to be followed by Jesse Krum. Jesse is been working with the IHI in the rural health updated report as a master's in public health candidate from the University of Nevada, Reno. And so he's going to be highlighting a lot of what has been found around mental health. And we're doing that because it's Mental Health Month in May. And so we always focus mental health during our May forum. And he's going to be showing what's been happening because that's a newer topic that was addressed in the 2025 Rural Health Report that was not addressed in the 2018 report. And then we're going to, I believe Tiffany will be in charge of helping you all get into discussion groups and we'll be report outs and develop some really, I believe, important insights and knowledge from all of you. So thank you very much. And I'm going to turn it over to Annie.
Hello, everyone. Let me just share my PowerPoint presentation. Share this. Okay, give me a second. Okay, can you see my screen?
We can.
Okay. As Victoria mentioned, my name is Annie Andreasian. I am the data analyst for Inland SoCal United Way 211 Plus. Um, Just as a brief overview, if you're unfamiliar with the 211, we provide information and referral services for the Inland Empire. We provide information on referrals, so CBOs and county as well as other organizations serving the IE residents, such as housing, utility, food, and mental health resources. I'm going to be following this legend here, so please feel free to screenshot for the presentation going forward. Okay. So our organization takes over 150,000 calls every year. Roughly about 98,000 of them are from our 211 INR line. Roughly 62% of the calls for the IE rural region that we took received referrals, and about 650 of those receive mental health related referrals. As mentioned before, we serve San Bernardino County and Riverside County. Just to briefly go into demographics. Um, so a majority of our callers tend to, around 80% in 2025, are under the federal poverty limit. And 44% of those who receive mental health referrals reported having no income source. So we see a correlation between needs needs of life and mental health services. Majority of our callers typically fall under the categories of Hispanic or Latinx, white, and African American, and that's mostly consistent across region. However, we did notice in Region 2, otherwise known as the Yucaipa, Beaumont area, that a good portion of our callers, a majority of our callers, tended to be African American. Around 60% of our callers are between 26 to
Super,
49,
Robert.
right? Around 50% of callers are considered single household or alone, and roughly 60 to 70% are identify as female. Okay. Um, as for our callers, most of the time when they identify within one of our target populations, they identify as being homeless, aging adults, or unemployed, victim of domestic violence, and disabled. And as you can see, a good portion of individuals who identify with Region 1, otherwise known as mainly Adelanto and Barstow, identify as being homeless. And that shows a positive correlation between having no income or low income, and it's consistent essentially. Okay. And now I want to go into more depth about what resources are actually being requested under mental health needs. So as I mentioned before, we provide a variety of resources, and our top three are housing, utility assistance, and food meals. And this is very consistent across the rural regions and across our services in general. And mental health / substance abuse disorders tends to be in our top 5 needs. And we've seen an actual increase in requested needs from 2024 to 2025 by around 10%. So, when we foresee that increasing for this year as well. Our top services under mental health needs tend to be substance abuse, crisis intervention services, and counseling services. You see, I've highlighted multiple that are technically under substance abuse services, and that comes out to roughly 33% of overall referrals provided to individuals in the rural regions. And some of our top most referred region is the Rome-Orland or Mid-County region, specifically Paris, Menifee, Wildomar. You'll notice that in this specific chart, there will be some where it's essentially nameless, and that's mostly because I was able to identify referrals that were provided by the zip code, but there was no city identifier. That's all that means. And in 2025, about 1,612 mental health referrals were created for IU rural region callers. This is actually a 70% increase, 70%. It was a almost 300 referral increase from 2024, which was about 1,300 mental health referrals. And like I said earlier, we do foresee this increasing. Our top most referred agencies include the behavioral health departments for San Bernardino and Riverside counties, including the Riverside County Substance Abuse Program, and additionally the Loma Linda University Behavioral Health. As you notice, a majority of our the top referred agency is the Riverside University Health System, under the Rome-Orland, Mid-County, aka Paris, and Menifee. I did not mention this before, but in addition to our 211 services, my organization also has the Crisis Helpline Program, which is a 24/7 crisis counseling service, suicide crisis counseling service. We provide information on mental health resources. We provide emergency counseling in times. There are cases that our counselors have had to call out to perform essentially a rescue. Additionally, we partner with Riverside County for the mobile crisis unit, which essentially is non-emergency service for mental health, in which they don't have the immediate need to, say, contact their therapist, or they're unable to go somewhere. So they provide almost a wellness check, or say they're out of their medication, they need additional services. We're able to facilitate someone going out to help them. So we see a lot of this high number of referrals to specifically Riverside County because we service Riverside County in this way. Okay. And I just wanted to briefly touch upon how Region 6, as I mentioned before, the Romoland Paris area, that has actually increased. The number of referrals has increased by around 70% from 2024 to 2025. And I just wanted to briefly touch on the crisis helpline, some of our rural metrics for that program. As I mentioned, most of our calls end up being from the low desert to Blythe and the Romoland Paris region, both Riverside County regions, just because we provide a good deal of services there. And we've actually seen quite a bit of increase from 2024 to 2025. Overall, we receive about 15 to 1700 calls per year, or sorry, not per year, per month in general to the crisis helpline. And last year, we received about 300 contacts from the rural regions, but this year we've gone to up to 546. And we've seen almost 50% increase of calls with suicidal content. So we're seeing that trend of increasing requests for needs in the mental health department, as well as just mental health services. So thank you so much for your time today. If you have any questions, let me know. Alternatively, if you are interested in further information regarding our data, you're more than welcome to submit a data request or send me an email. Thank you so much.
Thank you, Annie. That was really enlightening, especially the increases and where in the rural regions those increases are being shown. Does anyone have a question? You either put it in the chat
Okay.
or let Tiffany coordinate that.
Feel free to take a screenshot if you'd
Yeah.
like.
I just
And
had a quick comment. I just, kind of got in late. I heard you mention that you do serve the Blight area.
yes.
Okay, so how is that going? I don't know if I saw the numbers because I know that's there's always concern about that area not getting the services that they need out there.
So Blythe, um, I'll have to look a little bit more into exactly what services are coming into that city, but I do know it is pretty limited, and the highest number of referrals tend to go to the county or the behavioral health departments. So if you'd like additional information, you're more than welcome to leave your email and I can reach out to you regarding providing more information.
Thank you so much.
Yeah.
I do know that, and I don't know whether it's true for behavioral health, but I do know that the city of Blythe has been running buses into the Palm Desert area for their clients. And I don't know if that's just physical health or that includes mental health services. So if anyone on the call knows if Blythe is doing that with mental health services or if it's just physical, please speak up or put that in the chat. Because you're right, Hazel, Blythe is an issue. Services to Blythe is an issue, let me put it directly, and has been for a long time. So, and with Annie's permission, we will add her I'm putting you on the spot, Annie. We'll put your PowerPoint, the follow-up to this forum to everybody who's on attendance.
Yeah, I'll send it to you.
Okay, so you'll all receive this data in the PowerPoint presentation,
Mhm.
format rather.
So everyone's got it. I'll stop sharing.
Okay. Do we have any other questions for Annie before we move on to Jesse's information? Okay. And so as Annie said, if you wanted any specific information directly, please contact her. And they're very great. They're great. 211's wonderful about doing this. So second presenter today is Jessie Crum, and Jessie's an intern, master's in public health candidate from the University of Nevada, Reno, who has been working with the IHI on the updated rural health report. And so we've asked Jessie to provide some information on mental health because mental health was not a topic that was addressed in the 2018 rural health report, and it was added after COVID along with telehealth information. And that full report will be out July 1st. So you'll get information about that. It will also be on the Rural Health website, the ieruralhealth.org. And that's where the 2018 report is. So you'll be able to see both of them and do some comparisons. But I'd like to introduce Jesse and let him show you what the team and all the Rural Health Task Force members and agencies, some of whom are online today, so I thank you for that, have researched along with our interns from University of Nevada, Reno, and the Public Health Department, master's level. So, Jesse.
Right. Thank you, Victoria. As Victoria said, I'm Jesse Crum. I've been helping the IHI, which is the Inland Empire Community Health Initiative, with the Rural Health Report. I was not a part. I was not a part of the data collection process, but I am a part of the reporting process. So I've been providing guidance and feedback on the report itself and the data that's within it. And at this point, because we're publishing in almost a month and a half, just some kind of last minute edits, if you will, right now. But anyways, that's my little bit. I'm going to share my screen here. Right, perfect. So this is just an overview, whereas Annie's presentation, which was very wonderful, was very granular with its data. This is going to be a much broader look at the mental health data by region. So I'm just going to quickly introduce the service area and each of the regions. I'm going to go through mental health data by region. We're going to provide what the IHI has as far as recommendations so far, and then I'll open it up to questions. So it's a huge service area between San Bernardino County and Riverside County. They are respectively the largest county in California and the fourth largest county in the state of California, which is already a gigantic state. We have 6 different regions extending from the state border with Nevada all the way to the border with Mexico. So I'm going to put one more slide here that just shows the full scope of the service region. It's massive. It encompasses a lot of different communities and a lot of different community partners. So we are really grateful for those of you that are present and for those that have worked with us on this report. And I'll leave this up for a moment if you wanted to screenshot each of the regions real quick. All right. So these are the key indicators that the report used to determine mental health gaps. The number and availability of clinics and service providers, the availability of crisis stabilization or mobile response teams, and the availability of school-based mental health programs. Now, this is another, again, broad strokes overview of the barriers that we saw kind of cross-regionally. Some regions lack a county licensed psychiatrist. It says long wait times of 30 plus days. In some instances, it can be even up to 60 days, especially for Medi-Cal recipients where there is an even smaller pool of providers that accept Medi-Cal. And then long distance to receive care. 60 plus. In the mountain regions, it can be even longer. I personally live in a rural region of California, up in Mono County, and if I need to go to specialty care, the closest place I can go to is Reno, and that's a 3-hour drive minimally. So I live this. And the other barrier we identified was a lack of cultural competency and or humility and language skills amongst different providers. So now we'll move into each region. So looking at the high desert, and I do apologize. I know some of these images are going to be the zip codes are going to be a little blurry. I didn't create the images. I apologize. But the high desert, the specific challenges there as far as mental health services go are it's a giant service area. And 4 hospitals, 3 public health clinics. While that's a great spread from where I'm standing, where I have 1 critical care access facility in this entire county, that's still not enough for such a huge service area. The limited number of specialized providers, especially for people with intellectual and developmental disabilities, is a definite gap as far as mental health services go. And then with COVID, across the board, we saw an increased use of telehealth, specifically for mental health services. And in this region, in the high desert, unreliable broadband and a lot of multi-generational homes, which thus have a lack of private space to conduct that very personal, vulnerable kind of appointment, make accessing telehealth services not as consistent across the board as we would like. All right, moving on. I'm not trying to rush. I just know I have a few slides to get through, and I'm trying to stay within my allotted time. Looking at the Yucaipa, Devore, and Cajon challenges, a lot of the behavioral health services are centralized in San Bernardino. The lack of public transportation translates to a lot of patients that either don't make their appointments or don't even seek to make the appointments in the first place because they can't go to them if they have no private transportation. There's no public transportation. Culturally responsive care, again, like we talked about in that barrier, that cultural competency, bilingual aspect remains underfunded. I apologize. Should say underfunded. And then moving into the mountain region, which spans both Riverside County and San Bernardino County. There's a definite workforce shortage of providers. Seasonal road closures. Where I live at about 8,000 feet. I totally understand having snow and winter road closures, especially 2 years ago. But so having no access to services if you need to travel outside of the region is a huge issue. And then this was the long travel times for appointments for forgive me for writing Horace, 1 to 2 hours for appointment times just to get behavioral health services, which would be outside the region. All right, moving right along. We have the Yucca Valley Joshua Tree area. Again, common theme, limited number of licensed behavioral health providers that serve the entire region, and then the really long wait times, which I did touch on in the overview of barriers, of 30 to 60 days. If you're a person who needs behavioral health services, having to wait that long is so far from ideal, as I'm sure a lot of you can acknowledge. And the limit of school-based services represents a huge missed opportunity to provide early interventions to sort of provide younger people with the tools they may need to promote health and wellness early on in life and to kind of catch a lot of these issues earlier on before they become something of a greater burden later in life. Again, telehealth connection issues are a big problem in the isolated areas of the Yucca Valley Joshua Tree area because people can't, if there is no provider in that area and they have no broadband or connectivity with the broadband is spotty, they're not able to access that service at all. All right. Looking at low desert all the way to Blythe. The really mental health services specifically are very, very limited east of Coachella. The wait times, again, I know this is kind of a theme. I'm going to sound like a broken record, but they are very long. Up to 60 days in some places. And then in areas like Blythe, They oftentimes rely on visiting clinicians or emergency department visits, specifically for psychiatric care, which does disrupt continuity of service and establishing a rapport with a mental health provider. All right. And looking at the Romaland to mid-county challenges, outside of the larger cities, limited public transit options make it difficult, if not impossible, to make appointments if you lack a private vehicle. And then, like a lot of other places, they're under-resourced for behavioral health services, which means lack of providers, lack of clinics, lack of available appointments. And moving on to our recommendations. And again, these are cross-regional, and I'm going very broad strokes, just the top three. So providing incentives for rural behavioral health workforce recruitment and retention. Now, this could come in the form of student loan forgiveness, relocation stipends, bilingual pay differentials, a lot of different ways to incentivize providers to move to these areas to help provide these services to those communities. The second one, fund community-based peer support networks and school-based mental health programs. Some areas have one school mental health provider that has to go to each school in a district or in multiple districts, and that just isn't sustainable, and that leaves a lot of kids behind. So if we have some sort of community-based group that could help fill those gaps, that would address that problem specifically. And then integrate cultural competency training and translation services into all mental health programs. That's a big ask. I acknowledge that. Now, I know staffs aren't always going to be able to hire people that are bilingual. There may not be people in that community or people that are trained as a behavioral health provider that have that language skill. I know Language Line provides contracted services, and the racial equity and implicit bias statewide. Pardon me. The Racial Equity and Implicit Bias Statewide Initiative provides free trainings on cultural competency and humility. Any community-based organization just has to get in touch with them to request access. Does anyone have any questions? I know I kind of blazed through that.
And you will also get this PowerPoint, so you will have this information that Jesse's presented. So either raise your hand, speak up, put a question in the chat, because this is what we're going to be moving forward on. The information that Annie provided is a good foundational information across the board of unsolicited requests for mental health services. What I mean by unsolicited is that it's client solicited. It's not professionals going out and working or promoting this or engaging in it. What Jesse has provided is that broader, as he said, the broader strokes of what we're finding in the reports, but that more generalized, less very specific data, but very crucial data from mental health services. We all know, everyone on this call knows, that mental health in the Inland Empire is a tremendous issue. And we've got some changes going on at the state level, changes going on at the county levels, and we know that the two counties cross
I see a
over.
question
Yeah,
from
I see
Rebecca,
this
if I may.
Yeah, so I just saw Rebecca's question. Is this the data that will be coming out on July 1st? This is part of the data. So this is part of the report. The report is, I don't know what, 45 or 50 pages long, right, Jesse?
Just about, yeah.
Yeah, it's a very comprehensive report, but the mental health pieces will be part of the report. So the recommendations, for instance, there's a whole section on recommendations. This is just the mental health recommendations that have been pulled out for this presentation. So yes, the report itself covers 18 social indicators of health. The first report covered 16, and mental health and telehealth were added to the current report because of so it's kind of a pre-post COVID, what we learned from COVID for the rural areas. Do we have any other? Go ahead. I'm sorry.
I was just going to say, I left out that in the report itself, when we're talking about rural regions, it specifically refers to communities in each of those regions that are color coded, between 2,500 and 50,000 people. So just
Right,
to put it into perspective for everyone.
right. So the report, the full report, uh, only identifies rural regions and rural cities. And we really, at the original report, the committee really, the task force really looked at what was the definition of rural for the Inland Empire. And we used several definitions. So that's why, as Jesse's saying, the range of communities is 2,500 to 50,000. So anything over 50,000 was not considered a rural community. And so you will see a great deal of detail in each of those 6 rural regions that are color coded and drilled down by community and what has been found out in those communities. So I believe now it's time for you all to provide us with the feedback of what you're seeing because you are in the trenches, you are doing the work in these rural regions. And so we would like you to break out into discussion groups and come up. We provided 3 questions as guides strictly for you to discuss, but we really like you to then look at what would you do, what are you needing, what are you seeing, and how would you best use transformation funding, or how would it best be utilized in the regions that you serve? So I'm going to turn this over to Tiffany and let her guide you into groups.
Wonderful. Thank you so much, Victoria. So I'm going to open up the rooms. As we have kind of seen a few times, those color-coded regions, they'll have the name of the general region and the color. I'm going to have you guys assign yourselves, as I'm not sure exactly which regions that you are all individually in. And if we see that there are more in one group, we'll shuffle a little bit. But I'm going to open this up now, and I'm going to put the questions, they were on the program, but I'll put the questions in the chat so that you guys can reflect back on those.
And then we will give you an opportunity, we'll give you some time to discuss and come up with what you feel are the most important things. And then we will have you report out by group. And I have a question here. I'm pulling down.
Oh, that's the community discussion questions.
Right. Okay. So the discussion, while we're focusing on mental health data today, the discussion sections in your group is not limited to mental health, but what are you seeing as rural health challenges in your areas? Because the transformation money is not limited to, it's not focused just strictly on mental health. It's transformation money for rural regions. So you don't have to stick to just the mental health challenges, although as we saw today, mental health challenges are significant challenges in each of the rural areas. So
Absolutely. So go ahead and join your breakout rooms. Thank you so much, everyone.
I'm not seeing breakout rooms.
Are you all seeing breakout rooms?
No, I'm,
No.
Really? I see
You
them,
have
but
to
I have to
click on
click
the
the
you have to
settings.
click on the more button down below, more, and then
okay.
the breakout rooms will come up and you get to pick one.
Um, okay. Join breakout room. There you go. Okay. So thank you, Ben. So if you click on more, go to join breakout room, you have the 5 over there and just click to join the one you want to participate in. There goes everybody.
Okay, Victoria, I think we're all
Well,
back in
welcome back,
breakout room.
everybody. So interestingly enough, there were not a, there were not many people, or there are no people in several of the rural regions, including some of the larger ones. So, Tiffany, I'm going to turn this over to you and let you call up a group and see who in that group wants to report out.
Okay, sounds good. So I will
Oops, maybe I'm
start
not
with
hearing
the
me.
South Riverside group. I
Oh,
joined
that one. And I think
No.
Alejandro, you were going to be doing the share outs.
Yeah, can you guys hear me?
Yes.
Okay, good. So I was going to kick it to Tiffany and let her kind of coordinate, report outs from the different groups.
Yep, we're gonna have Alejandro go first,
Okay.
to do the South Riverside.
Yes. So for the South Riverside breakout room, at least for the first question, the three major mental health needs, one of the things that they talked about was the need for more adolescent services, specifically for ages 12 to 18. They really wanted more services that would have a virtual component as well, just because there is like that difficulty for accessing like inpatient, in-person access, usually because of the locations and like scheduling, for example. Another mental health need was actually brought up. That was brought up was for early childhood services like 0 to 6. um, Sometimes parents tend to struggle with deciding whether they should pull their kid out of school for the appointments or just keep them in school. Like, will they miss anything important? Which most likely they will. Or should they get the services? Sometimes there's that stigma as well. Someone brought up that not all parents have enough information when accessing services. They might rely on just hoping things get better or things change, or for example, in rural areas, maybe they're instead of listening or wanting to seek out medical professional help, they might rely on like religious leaders, for example, who, yes, if it brings them comfort, that's good, but they're not necessarily the mental health professionals, the medical professionals. So there's just difficulty in navigating the system. That kind of segued us into the second question, which is challenges. So barriers that we spoke about were, for example, working hours for parents, transportation issues, um, changes in insurance rules and regulations. Um, Kids missing school, the hours of availability, so the working hours of the providers, and also stigmas for therapy. So not everyone sees mental health needs, mental health appointments, therapy as important as, for example, a dental appointment or a medical appointment. So they don't necessarily have it as a priority. Um, some folks talked about if we should do an MOU, just establish contracts to provide services, or even utilizing more community health workers to at least help parents, to help community members establish and navigate those systems. Someone spoke about how the Inland Empire is a very industrial area. So, for example, warehouses, they tend to have varying shifts. So families don't always have the same work schedules. You can't expect a regular 9 to 5 from this area. A lot of folks have varying shifts, and maybe an online option that doesn't necessarily take insurance could be a good solution. For example, someone spoke about BetterHelp. um, People use that service. Money is also a barrier. So therapy, medical appointments, families might struggle to choose whether they should go seek therapy or pay for their bills, pay for food. That's a harsh reality. Um, and even just lack of communication. So there's a lot of red tape. Sometimes you need like a diagnosis, you need an IEP just to access certain services, or maybe the folks that connect you to those services, they don't find out about certain programs that could really be beneficial to families until like months later, weeks later. And then how would you use your funds for question number three? Basically more virtual services. And someone also said funds as stipends, like an HSA.
Mm, interesting. Thank you.
Mhm.
Thank you so much, Alejandra. Can someone share out from the Yucaipa Cal Mesa Devore group?
I'm happy to do that. I hopped in a little after they'd started. Um, so we talked a little bit about mental health needs, but we kind of went in a more general direction as far as like access needs. Um, we talked about a lot of people there's kind of a gap in quality of care in that people are getting a diagnosis and then not having any kind of like follow up or education on what that diagnosis means and maybe why or things that contributed to that diagnosis. Um, we talked about barriers to services, access barriers, and that if there were to be funds, that a lot of them should be driven towards telehealth because that's kind of one of the only ways for mental health services to really get into some of these communities that lack infrastructure. We talked about the importance and something that maybe doesn't get talked about as much of social connectivity and kind of that social we as humans are social beings and having those connections is vital to not just our mental health but our physical health as well. And so having events and knowing your neighbors, things like that, are important things to kind of foster to promote positive mental health as well as physical health. And then another potential funding target could be this is more for physical health as opposed to mental health, but mobile clinics in these rural regions that don't have services. I know where I live, we've had success with that as far as we've used dental vans before. Yeah, and we covered a little bit on social determinants of health. And so that's what our group discussed. Feel free to chime in if I left anything out.
No, you got it, Jesse. You got it.
Thank you.
Thank you.
Thank you so much. And Jesse, the mobile clinics, I always try to push for those. And one of the feedbacks that I've received for San Bernardino, I think, is that some of the rural regions are so large. It's like, where is an actual accessible place to put this mobile unit at? Where is the who do we have to contract? What's the permits? It's something that we kind of talked about in our group with the South Mid Riverside is that sometimes there's so much bureaucracy, so much red tape, so much logistical planning, and then you need someone like a city planner to hop in and have that conversation, right? Just so that you know where you can go. And I love that. Mobile clinics, incredibly helpful.
I do have one question for Victoria, and you can address it at the end. It was actually about the Rural Health Transformation Fund specifically, and how they're going to be dispersed. Are they going to be dispersed directly to nonprofits, CBOs, and is that coordinated through counties?
And we do not have that answer yet.
Okay,
There is
that's
a committee up in Sacramento who's trying to figure that out.
wonderful.
And so our state CCHI is involved in that. One of the advisory members on the IHI's advisory council is also involved in that. Jody Wenger, the CEO from Chazar, the community clinic. And I'm just really curious as to see what the RFP is going to look like and how we're going to address it in the Inland Empire, because I really would like to eliminate the silos, and I would really like to eliminate the competition and work collaboratively and what I call complementary so that we draw down all the money and it's dispersed equitably within each of the 6 regions. But I don't know what that's going to look like until we see the RFP. Anyway,
Thank
but we
you.
were hoping things like this would start some of that dialogue so we could start thinking ahead about where the challenges are and what might be some of the solutions and some of the funding solutions in the 6 regions. So anyway, but I appreciate the question, but we will keep everyone on board as soon as we're here.
Absolutely. And then we have one more group to share out before we close. So Low Desert to Blythe. Did you guys have a speaker?
We didn't designate anyone particularly. Alejandra, do you want to share a little bit of what we talked about?
Sure. Well, not a lot of folks in our group were from the region, but we had a lot of interest in the Blythe area since it's kind of so separated out there. We were talking about how the Coachella Valley um, is similar to Blythe in some of its regions, but that we have a lot of like disparity in between the different communities in the Coachella Valley. So one of the main things that we did talk about was stigmas around mental health in the communities and access to these resources. We weren't quite sure if there is some sort of mental health hospital or clinic out in Blythe, but I know that at least the one out here in Indio, it's the main one for the entire Coachella Valley, at least by the county, right? And growing up, I remember for people in rural communities, especially like the Salton Sea area, it's like what, like over an hour away, or maybe like around an hour away. Sometimes like the police would be escorting students out of the schools to take them to the mental health facility, which just adds to the stigma and begins to criminalize this behavior. And we also talked about how the effects of like ignoring mental health or not addressing these issues, like the negative effects it has on communities and increased violence, family violence, and even for students or youth who are not addressing their mental health issues, it's a lack of motivation and a lack of progress, um, which just leads to so many things. So it's a very big and long cycle. So it would be really great to get some resources out to the community that are a little bit closer. We also talked about just how different regions are in California and in Riverside County, and how unique this region is, right? And unique in its struggles as well. But overall, I'm hopeful that we can get some resources out there, and even seeing recent data or survey results from Desert Healthcare District showed us that students are more open to using mental health source resources over online or on on a virtual platform. So maybe that would even open up the door a bit more and encourage a little more use, even among the family, right? Encouraging people reach out to mental health resources. You're not sure if I missed anything. Feel free to jump in and add anything I forgot about.
Anybody else from that group want to address anything or share anything? Okay. We didn't really talk that much about how to use the funds, but some very interesting perspectives came out about things out there. We have a comment from Ben that I want to share, unless Ben, you want to share it.
Sure, I just mentioned that all mental health systems, they need to integrate peer support specialists or community health workers so they can help address the health-related social needs, because I think that's a barrier that always exists wherever you're at, and especially rural areas where there's lack of social services and other needs, and lack of housing, and rural areas are known to be food deserts, and how do we address all those other things that are barriers to or prevent people from even accessing care because they're focused on those social needs, health related social needs.
And I agree that community health workers and peer support specialists have a really important place. My concern through this whole mental health thing is that we don't have enough mental health professionals. And so while we can use peer support specialists and community health workers at one tier, the tier above is destitute. And there are no, for instance, there are no certified play therapists in the Inland Empire, which means there's no appropriate early intervention mental health services for children under the age of 7. There's just none. And this idea that talk therapy is a vehicle for children and teens is also not functional. They do not respond well to talk therapy. And yet the majority of what we offer children and teens, school age children and teens, is a talk therapy format. And that's not realistic. And we had talked about, I think in our group down about Low Desert, we also talked about the lack of family counseling services, that even when they're contracted out, there aren't enough professionals to provide the services. So And IEHP, I think, is still on the line. They've discovered that with other things, they've purchased transportation contracts with facilities that provide transportation. And yet they won't go to the rural areas or they won't go up to the mountains in the snow, which means that seniors and families can't get down to appointments because the vehicles won't go up to get appointments. So I want to thank all of you for your time today, your insights, your discussions. I think there's only two, and I know it sounds like a lot of money in some respects, but it's only $232 million of transformation funding for the state of California. That's not even enough to scratch the surface in the Inland Empire. So we will stay in touch with all of you. And please stay in touch with us. Anything that you have in the way of ideas, thoughts, streamlining ways of providing services that are most cost effective but have strong impact. This is a huge issue. So any last comments or thoughts before we close for the day? All right. You will receive this. It has been recorded, and you will get the PowerPoints. Thank you so much. And thank you to Annie and Jesse for their presentations and for Tiffany for coordinating everything as she does so well. And for all of you for being here and giving us your time and your input and your thoughts. Thank you.
Thank you.